Hello everyone, this is Dr. Pruitt. I am really excited to be talking to you today about a new program that we have honestly been working on building in the background for close to a year now. It's a program that involves EMS-initiated Suboxone administration to our opioid addicted patients, and it's a program where we can get them directly to the care that they need. We're calling this program the Golden Opportunity, and so today I get to tell you all about it. As you know, I know this is not a news flash to any of you. We're living in the thick of this opioid epidemic, and if it feels like it's worse than it's ever been, that's because that's true. If you look at these graphs here with the national drug overdose deaths, and these graphs only go up to 2022, but you can see the profound spike in deaths related to synthetic opioids on this graph here on the left, and then the one on the right is also showing just over the last 10 years, folks who are dying from drug overdose deaths have more than doubled in the last 10 years. And so this truly is an epidemic that we need to be talking about and figuring out what we can do better, because what we're doing right now doesn't seem to be making a difference. In fact, all of these charts seem to be trending the wrong way. So when you look at New Mexico compared to what's happening nationally, you can see that based on some Department of Health statistics that we have, you have the national average drug overdose death rates going back to 1999. The national average is that orange line there at the bottom. And you can see the blue line there is New Mexico. And we had a pretty profound spike in 2020, which we all knew. But those numbers have stayed high and are much higher than the national average, which is not where we want to be. In fact, if you look at the number of deaths that we've had, in 2021, 2022, the numbers are pretty similar. There was over 1,000 New Mexicans that died drug overdose deaths that year. That means that there's a New Mexican dying specifically of an overdose every 9 minutes in this state. And most of those deaths are involving fentanyl. Again, not a news flash to us. We're living this, we're seeing it every day, but it's important to paint the picture of where we are and how we think we can get better. So compared to the rest of the nation, New Mexico actually has the 6th highest overdose death rate in the nation. You can see we're one of those dark blue states there where our death rate is exorbitantly high due to drug overdoses. And again, no news flash, but the majority of this is due to fentanyl. Methamphetamine causes a fair amount of deaths, and some of these are co-ingestion of substances, but by and large, the drug that we're trying to address and that we need to be talking about is fentanyl. And how do we do better with this as first responders and as a medical community to treat these patients better? Right now, pretty much all we have in our toolbox is Narcan. And you and I both know it's great. It definitely saves lives. For the folks that we get there, they're not breathing, they're close to death. We give Narcan, they wake up. It literally raises people from the dead. And in that respect, it's a pretty amazing drug. The frustrating part with this is we all know that it's just a Band-Aid. We know that unless we treat the addiction or get these people the help that they need who are addicted to these opiates, Narcan is a short-term cure. It's not a long-term cure for a very complicated disease, and we truly need something more. We've been giving Narcan out for free. There's communities that have Narcan vending machines. We're giving Narcan to everybody. It's available over the counter now, and despite the availability of Narcan, the drug overdose deaths just continue to rise, and this epidemic continues to get worse year after year. So it's absolutely time, and I know you probably agree with me and hopefully are feeling this, that it's time we've got to try something else. And we know that after EMS reverses someone with Narcan, the risk of death, even after a non-fatal overdose is reversed, the mortality remains high at 30 days all the way out to a year. So there's been several studies that followed patients who received Narcan in the field and their overdose was reversed, and they either went to the hospital or they didn't. But we know in some of these studies that there is a 1-year mortality rate. That means this patient will be dead in 1 year. There's a 5.5% chance that that patient that you just reversed with Narcan is going to be dead in a year. Now, to put some context on a 5% mortality rate, the 1-year mortality rate after a STEMI, so after somebody has a heart attack, and we know typically they're not like the picture of health, their mortality is 7%. So the mortality from a drug overdose is just as high as someone who has had a heart attack, just as severe. And not only that, but the folks who were discharged from the ED after a non-fatal overdose, they followed those patients through another EMS system, and almost 1 in 5 of those patients, 22%, died within the first 48 hours after leaving the ED. And so just because we reverse them, just because we get them to the hospital, their mortality is very, very high. And we know that it's even higher for the folks that we reverse with Narcan that refuse to go to the hospital. One study showed that their mortality after they refuse EMS transport, after they wake up from the Narcan, can be more than 13 times higher than the age-adjusted rate for the general population. That means for an average 25-year-old compared to a 25-year-old that we just reversed, they have a 13 times higher chance of dying simply by the fact that they just nearly had a fatal overdose, but they were saved by Narcan. So, and we also know that EMS is the perfect place to interface with these patients because not all of them do go to the hospital. And 30% of these folks who died within that first year had some sort of interface with EMS. And so we're at a really nice crossroads where we can hopefully make a difference for these patients. And my plea to you today is that hopefully by the end of this talk, we can start to see these patients through a different lens. And I know this is a little bit of a sales pitch, but I hope that I'm appealing to the part of you that's a little bit tired of just giving Narcan and you're wanting to do something more. And if we start to see these patients as complex, complicated patients with a chronic illness, so just like people with COPD or CHF or heart disease or diabetes, this really isn't that different. It's a complex chronic disease that until we start talking about it like the disease it is, I think it's going to be hard for us to make that mental shift. So to put this in context, we already know that the mortality for an opiate addiction or substance use disorder is pretty much just as high as severe cardiac disease or maybe even cancer. And when we talk about cancer patients, just for instance, they have a very high mortality. It's a very complicated disease. Cancer patients have these things called tumor boards, where they get together, the whole team of experts that talks about an individual patient with their individual needs and their individual cancer characteristics. So for instance, when the tumor board meets for a cancer patient, they have a surgeon in the room, and they have a chemotherapy doctor, and they have a radiologist there, and they have a medicine doctor, and they have a counselor and palliative care, and a whole team of experts, sometimes 9 or 10 people, that will look at the patient's scans and their lab work and their history and really go into detail on very specific patients to come up with a perfect plan for them. And ideally, I think very similar approach is what we need for substance use disorder patients. And until we start to treat them like the complex patients they are, and we're not going to have the results that we want on this epidemic. And so if we have an interface with public safety and public health and EMS and primary care and case management and things like that, I think these folks will do a lot better. And it has been shown, we're at the point now where other people have done this and done the studies for us and have shown that this is what's effective to get people back on track and back on the road to recovery. Is a multi-pronged approach with a lot of different experts, just like the tumor board for our cancer patients. And so if we start to see these folks, if you think about it, if we have someone who's having a heart attack, the heart attack patient will go to a STEMI center, right? We know that that's the intervention they need. Or similarly, if we have a level 1 trauma patient, those patients go to a trauma center because they have the specialty care that that patient needs. Well, the idea behind this program is that this is a specialized patient population as well. And so now our substance use disorder patients, we're going to give the option to go to an addiction treatment center, which is revolutionary because right now the ED is not specialized in treating substance use disorders. Sometimes they can, sometimes they don't, sometimes it's hit or miss. But with this program, we're going to get these patients to the specialized care and the specialized team that they need that's going to give us a better chance to get them on the road to recovery. And so when you look at all the pieces of the puzzle that our substance use disorder patients need, like I mentioned, it's a whole lot of different things, right? They need primary care. A lot of them have neglected underlying medical issues or have developed new ones over the years. There's peer support, someone who can speak their language and walk them through the process of recovery. Counseling, many times there's underlying mental health issues or other substance issues, maybe trauma that had incited the beginnings of this, case management for housing or other support that may be needed. And then, of course, our piece that we're most interested in is the medication-assisted treatment. And study after study has shown that until you start to treat the addiction with medication, all those other pieces don't really matter that much. And so our goal here today is to initiate that medication-assisted treatment as soon as we possibly can to get them on that first step, honestly, on the long road to recovery to get them where they can do these other pieces as well. And so right now, if in the substance use disorder treatment world, there's basically 3 options for medical treatment for folks who are addicted to opiates. And I'm sure you've heard of all of them before. Methadone is very common and works for a lot of people. The way that methadone works is it's basically a full agonist at the opioid receptor, so it does stimulate that receptor. It has potential for abuse because it can make that patient high. There is a risk of overdose, which is why it's highly regulated, and it's usually dosed daily, and sometimes some of the requirements around methadone administration can be a little bit onerous. So methadone isn't the right treatment for everyone, but there definitely is a population of patients who have been on it for years and are doing well on it, staying stable. But it's not something that we can give in the field just due to the requirements around it and the potential for abuse. There's another drug called naltrexone, which is actually an opiate antagonist, which means they can't get high at all. It fully blocks the receptor and can put patients, you have to go through some pretty serious withdrawals before that one becomes effective. But there is a population of patients where it is very effective, and they know if they go get high, it's not going to work because those receptors are blocked. And so naltrexone is also an option. But the one that works best for us and is becoming more popular and is getting studied a lot more for its effectiveness is a drug called buprenorphine, and it's also known as Suboxone. So I imagine you've probably heard of it before, but just to go over the basic pharmacokinetics of it is it's a partial agonist, and so it does stimulate the opioid receptor, but just enough to stave off the withdrawals. It doesn't make people necessarily feel high, it just helps them feel better. If you've ever talked to someone who's had opiate withdrawals before, they're awful. It feels like the worst flu of your life. You have goosebumps, you have chills, vomiting, diarrhea, anxious, just feels terrible. And with buprenorphine, it takes away a lot of those withdrawal symptoms, but you're not able to overdose on it. It actually has some Narcan hidden in it, so you can't get too much respiratory depression from it. Now, I imagine if you probably took enough Suboxone, yes, you could probably overdose and have respiratory depression. But the idea behind the drug, it's still highly controlled, so it is a narcotic, and there is some Narcan in it, but also the buprenorphine is the active chemical. And this is the partial opioid agonist that blocks the receptor so that future opioids can't get on there. You can't get high when buprenorphine's on board. It is just enough to keep the withdrawal symptoms at bay. And so it really, truly treats withdrawal. Now, historically, this is a great option, right? For treatment, you're like, great, you can't get high, you can't overdose, but it'll help them feel better. Sounds perfect. Well, in the past, the biggest hurdle to patients starting on Suboxone was that they had to be in withdrawal to start it. And if you talk to anybody who's been addicted to opioids, the withdrawals are so terrible. People will do anything to avoid going through withdrawals. And so a lot of patients were hesitant to start Suboxone because they didn't want to have to go through the withdrawal period until they could get the medication. Well, just so happens to turn out that after we give Narcan in the field, we just put them in withdrawal. So that's probably a perfect time to start it, which is why we're having this conversation. We're going to be able to overcome that initial barrier to treatment that had been present for so long. So if you are asking the question, okay, well, buprenorphine sounds good, what is the evidence? Well, buprenorphine has been studied a lot over the last couple of years. And there was one study, this first one here, that's highlighted in green. This was in a substance abuse magazine or journal talking about starting buprenorphine after non-fatal opioid overdoses. And they followed over 10,000 people who had been reversed with Narcan in the field. And what they found was that by initiating buprenorphine, and I think this was a study that was done in the ER, they decreased their likelihood of a subsequent fatal overdose by 94%. Which is huge. If you think about these patients having a 13 times higher mortality and you can reduce that by 94%, that's wonderful. Not only that, but this blue one here from the Annals of Internal Medicine followed 2,000 non-fatal overdose patients. So these are also ones who had received Narcan and then they followed them out for a certain period of time. It didn't just decrease their mortality from a future overdose, it also decreased all-cause mortality. So we're talking trauma, heart disease, diabetes, all the other things in addition to opioid-related mortality, because we know that when we get people's addiction treated, then we can get them on the road to treating all the other aspects of their life that may need to get on the road to recovery as well. So things like primary care. This purple one here, this was in a preventive medicine journal. This one followed over 80,000 Medicare patients who have extensive records that are available for review. Again, after overdose that was non-fatal, so they received Narcan. Buprenorphine administration was associated with a 62% reduction in the risk of opioid-related death. And so we know that buprenorphine can help these folks decrease their mortality and get them on the path to recovery. I thought this graph here was very telling. Let me narrate it for you, but this was published in the Journal of Internal Medicine a couple of years ago in 2021. And this was predicting mortality. They basically had people with substance use disorder who are addicted to opioids in two groups. And the yellow group here basically just got some counseling and some resources and a pat on the back, like, you got this, you can do better. Not a whole lot of medication assistance, just offered a pamphlet with some phone numbers to call for help. Compared to the blue group, who they got to choose, so they could have medication-assisted treatment. So they could either have methadone, they could have buprenorphine, or they could have naltrexone. All three of those drugs, like we talked about, are approved for use in substance use disorder, and these patients got to pick. Look at those mortality rates. And so they stratified the patients by who was the riskiest for overdosing, who was least risky for overdosing, and by any percentile of risk stratification, they cut mortality pretty much in half in every single category by initiating treatment with medication. These numbers are really hard to argue with. And once they got this medication treatment going and sustained, then they could address all the other things that need to be addressed, whether it's mental health, counseling, housing, case management, whatever the case may be. It all starts with medication-assisted treatment. And so huge impacts on mortality here. Now, you may ask yourself, was anybody else thinking about doing this? Well, actually they have. So in Camden, New Jersey, their EMS system there has been doing EMS-initiated Suboxone for a little while now. What they're seeing is substantial decrease in the CALS score, which we'll talk about in a minute, but basically the withdrawal symptoms are going away by treating these patients. Not only that, but a 12-fold increase in patients who are enrolled in continuing care and on the path to recovery at 30 days out after EMS-initiated buprenorphine. And importantly for us, and I know this is of concern to a lot of people, their on-scene times did not substantially get any longer. So the average is a little more than 6 minutes on scene after a Narcan reversal compared to folks that don't go into this program. So really not prolonged scene times, not a heavy burden on EMS, and it's making a huge impact for some of our sickest patients. California Bridge program is another one. They're seeing a 50% retention rate at 7 days, and then a 36% retention in treatment at 30 days out, compared to Florida, who's seeing a 60% retention in treatment. So this is not the perfect answer, but it is making a difference for a lot of people where otherwise, with just the standard Narcan treatment and transfer to the ED, wouldn't have gotten so many people on the path to recovery. There's also growing programs in North Carolina. San Antonio Fire is doing this really well, and also in Seattle. So most of the big cities are attempting this. I think a lot of people are seeing like just giving Narcan is not really helping, and we need to try to do something better. And so this is where we come in. What's it going to look like in Albuquerque? So if you take your standard overdose right now, let's say you show up, someone is turning blue, their sats are 36, they're barely breathing, you recognize the pinpoint pupils and the whole setting, and you give your Narcan, or maybe somebody else already gave the Narcan, whether it's PD or a bystander. That happens a lot these days. The Narcan doesn't have to come from us. But if they did just get reversed from a severe opioid overdose, do your normal assessment. Everything stays the same. So look for signs of trauma, think about critical illness, get a good set of vital signs. And then once they wake up, if this is kind of a standard opioid overdose, if they wake up and they maybe start to vomit, or they maybe start to salivate or tear or have the goose flesh, and you know that they're in withdrawals, this is where typically we would give them an option. Either you can go to the hospital, or sometimes they just get up and walk away. And so more than that this time, this is where the golden opportunity comes in. If this is the patient who wakes up and is starting to want to walk away because they're feeling terrible and they need to go get rid of that withdrawal feeling, and probably honestly go get high again, to feel better, this is where we offer them the golden opportunity. And so all it needs is you would still sign the refusal, so assuming they still have capacity to understand their situation and understand what happened and decline the transport to the hospital, we would still sign the refusal, but we could offer them transport to a place that can do their medication-assisted treatment, and in fact, we can start their treatment right now. And so I think this is where we can catch them, is those withdrawal symptoms are going to be so overwhelming and so miserable. If you offer them Suboxone right there in the moment when they're feeling bad, hopefully they'll take advantage of this golden opportunity to get on the path to recovery. And so when we think about these patients, in my mind, I kind of think about 3 possible outcomes after we've reversed somebody with Narcan. You'll have this first patient here who's passed out on the bench. Sometimes we give Narcan and people don't wake up, and there's still something else going on, or maybe they have a mixed set of drugs on board, or it's a totally different cause of altered mental status. If they do not wake up and do not demonstrate capacity and have unstable vital signs or any other concerning thing, if they cannot demonstrate capacity to consent for refusal, that first patient there needs to go to the hospital in an ambulance, right? I think we would all agree on that one. But then now we have another patient population that is awake, that is conversant, and can understand what just happened. And here's where we have 2 options now. One may be angry at us and just want to walk off and sign a refusal, and that's okay. That's their right. But this third one here is the one that I would try to have a conversation with about, look, I know that you are probably feeling terrible. I can offer you some medication to help you feel better. In fact, we'll give you a ride to go get some treatment. And I would hope that the conversation would go something like that. You know, you almost died. If somebody didn't give you Narcan, you could be dead right now. You know, some people, that doesn't motivate a lot of folks. That's okay. But you know what will motivate these folks is the withdrawal symptoms that they're feeling. So you can acknowledge that they're probably feeling terrible right now. Offer them medication that will help them feel better. The Suboxone will take away those withdrawal symptoms. And then kind of cut down the craving to go get high again. Meanwhile, getting them to a place where they can get those other wraparound services that they need while still addressing their medical needs. And that's why we call this program the Golden Opportunity. So the guideline, we'll have a new guideline for this. It's going to look something along these lines, where basically anyone who has been reversed with Narcan, if they're consentable, should be offered this drug and an alternative path to treatment. So this is our first truly alternative destination in our system. What we'll do, so in order to assess for their dose of buprenorphine, there's something called a COWS score. So let's say this is a patient who just received Narcan from anybody. It could have been police, bystander, from us. They wake up. They are consentable. Their vital signs are relatively stable now. They're making sense. They can hold a conversation. They can understand what's happening. You offer them the Golden Opportunity. At that point, you can obtain something called a COWS score. Now, it's called the Clinical Opiate Withdrawal Score, and this is built into Image Trends. So you just click some boxes on the symptoms that they're feeling, and you want to make sure that you're asking them about symptoms, not chronic symptoms. We don't really care if they've had chronic nausea. We want to know if they're nauseous right now after the Narcan, and that's how we score this. But you should be able to just click boxes on the computer. This is built into Image Trend. Should be hopefully pretty user-friendly, and it'll automatically calculate the score for you. So we look at things like pulse rate or goosebumps on their skin or maybe active vomiting. There's several different things that we can score. And if they score a 7 or higher, that means they qualify for a first dose of buprenorphine, which is 16 milligrams. Now, once they consent to this program, we need them to know that we'll give them this medication, but what it means is that there's going to be a car coming to the scene to take them to a different destination. And so for the metro area, for Albuquerque Fire, our designated transport, instead of 5-5, for this program in particular, it's going to be ACS. And they have assured us that they're going to make this a priority call. So the minute you get the verbal consent from this patient that they want to do the Suboxone or the buprenorphine and they want to take advantage of the Golden Opportunity, I would call our dispatch and ask the law enforcement dispatch to send ACS to the scene, and they should be there within 10 minutes. And what that does for you is it gives you time to assess their COWS score, ask them the questions, obtain their score, and give the first dose of Suboxone. Now, the Suboxone that we're going to be giving more than likely is going to be little films that dissolve on the tongue. And so there is a subset of the population that their mouth gets really dry with withdrawals, and so you may want to offer, if they have water or something available, to kind of moisten their mouth so the medication absorbs a little bit better. Because if the medication can't absorb, it's not going to be useful or help them feel better. And so just a little thing to consider when we're giving that first dose. We want to see if we can moisten their mucous membranes a little bit so it absorbs. And then we have 10 minutes to reassess them. So hopefully in that 10 minutes, ACS is on their way to the scene. The patient has already signed the refusal. After 10 minutes, we reassess their COWS score. So we score them again. If they're still scoring greater than 7, we can give one more dose of 8 milligrams of Suboxone if they need it. It's very rare that people need any more than that, but this should get them into a comfortable place where the withdrawal symptoms are at bay, feeling a lot better, so then they can cooperate with the next steps in their treatment. And so when we think about transport from the scene, which I'm sure is going to be foremost in a lot of people's minds, so we've reversed this patient with Narcan. They have woken up. We've obtained consent for EMS refusal of transport. They say they want to partake in the program. This is how we call ACS to the scene. So I would do it even before you give the first dose of Suboxone. You want to ask the alarm room to contact APD dispatch and ask for an ACS transport for a golden opportunity patient, and they're classifying these as priority 2C. That verbiage for the PD dispatchers is very important because that basically bumps them up in priority and will get them to your scene as fast as possible. And on your CAD, it's going to look like ACS Go for golden opportunity in the P1 CAD. So that's what you'll see. And they've told us that they'll have a unit there within 10 minutes to take that patient to one of our partner agencies to continue with their treatment. Now, if it happens that the transport unit is delayed greater than 10 minutes and you're already on your second COWS assessment, kind of standing there looking at your watch, contact the alarm room. They have a list of supervisor phone numbers that they can call the supervisors and help get someone to the scene faster. And so ACS is very committed. They've been good partners in this. They're very committed to this program. They're very excited about it, and I truly think they will prioritize these calls. And so I think their transport should be very reliable. Now, the patients who are not going to be eligible for this program, and these are the exclusion criteria that we'll assess for before we give any doses or consent for the program. If they obviously, and most of these will be intuitive, right? If they don't have capacity or they're still altered and they can't truly meet refusal criteria, they're not going to be in any state of mind to consent for this program either. And so those are the patients where probably just historically we take them to the hospital, and that's still the right idea here. Also, with unstable vital signs, if their vital signs are wildly unstable but they're walking away or refusing care, we'll have to let them walk away or refuse care. But if their vital signs are unstable, these are not patients that we can load in the back of essentially a civilian car and take to a clinic. And so there are some vital signs abnormalities outlined in the guideline, but basically if their systolic blood pressure is less than 90, if they're still profoundly hypoxic after the Narcan, or having trouble breathing, or their heart rate is greater than 120 after the buprenorphine, those are all things that probably aren't stable enough to go just sit in a clinic and wait for further care. Also, if they're still having serious medical complaints, we should encourage them to go to the hospital. Shortness of breath, trouble breathing, chest pain, still confused, or serious trauma, all those need to go to the hospital as well. And then if you have folks who are on chronic narcotics, and so methadone, if their body is used to having methadone in their system and they're chronically on it, Suboxone is not going to be as effective for them. And so those patients are not eligible for this program. And also folks who are prescribed chronic narcotics for pain. So let's say somebody has chronic back pain and they take oxycodone every single day because their back hurts. Well, they're probably not going to be a good candidate for Suboxone either, because Suboxone is not going to treat the pain. It's just going to block the receptor and keep the symptoms at bay. So those aren't ideal patients for this. And then I have never heard of this. I've been talking to some addiction experts. They've never heard of a true allergy to Suboxone either. Some people have taken it in the past and it's made them feel weird, probably because they weren't in full-blown withdrawals when they took it. But you can ask if they have an allergy to Suboxone, and I would just ask them what that is and what symptoms they had, because if they say it just made them feel weird, that's probably not an allergy. True allergy, as you know, is trouble breathing, throat swelling, voice changes, drooling, rash, any of those things. If they list those as allergy to Suboxone, then they would not be eligible either. So just things to keep in mind. But let's say they don't have any exclusion criteria, ACS gets there really quickly and is willing to take them. The next step, we have 3, maybe 4 community partners in this who have agreed to take these patients without a prior appointment. And so we can ask, we'll give the patient the choice between these 3. First is Duke City Recovery Toolbox, and their hours are Monday through Thursday, 5 a.m. to 11 a.m. The CARES campus actually has wonderful programs and some continuing treatment there, and they're open 24/7. So in all reality, probably considering the days of the week and the times of day where we reverse most of our opioid overdoses, CARES campus is probably going to be the most likely destination just due to hours and availability. But there's also Courageous Transformations, who's open Monday through Friday, 6 a.m. to 1 p.m. to receive these patients. And all of these partner agencies truly believe in kind of this holistic kind of treatment that I described earlier, with case managers and counseling and peer support and primary care. Each one of these has the total wraparound package, in addition to the ability to prescribe ongoing Suboxone for these folks to get them the medication-assisted treatment that they need. And so these are our golden opportunity partners. Like I said, CARES Campus is the only one that's open 24/7, so in all reality, they'll probably be getting the majority of the patients, but these other 2 clinics are wonderful community partners and may get some of these patients as well. So when we document these encounters, anytime you administer Narcan, you're going to get a little reminder prompt in ImageTrend to just ask if you gave Suboxone. Some patients, let's say they don't wake up and they clearly have to go to the hospital, you just click non-applicable. But it's just a little reminder in the validation rules to prompt you to ask. And then if you do and you get consent for the Golden Opportunity Program, there's a calculator in there with that COWS score, the withdrawal score that we talked about, so it can help you do the math. I know I always need help adding, so it's nice that the computer does it for you. And then you just use the drop-down menus to select your buprenorphine dose, or if you have to give a second dose, your second dose as well. And then just for disposition purposes, remember this will be an EMS refusal of transport since we're not going to the hospital. But if ACS comes to the scene, there's some other options in there now that involve the CARE Campus or Duke City Recovery or Courageous Transformations as alternative destinations for these patients to go. And really, that's it. I hope you are as excited about this program as I am. I know it's a big change, but I think if we're going to make any sort of difference in this epidemic, it's going to start with this. And I know we all hopefully got into this career field to help save lives, and these are truly lives that we know have super high mortality and need this care and need this intervention. So I hope that you'll participate in this program and let me know how it goes. Thank you.